this session, Ken Caldwell shows Joe how to conduct a respiratory assessment. Respiratory assessment requires a systematic approach of inspection, palpation, percussion and auscultation. Knowing the landmarks of the chest will help you understand where you are looking and what you are looking for.
Is this area here, which is called the suprasternal notch. Okay, the borders of that are the sternocleidomastoid muscles. Okay, they're part of the accessory muscle system that actually helps the chest rise and fall. Okay. Particularly if they're short of breath, they'll actually start using those accessory muscles even more. Alrighty. Particular about this area is that bordered by the sternocleidomastoid muscles is in between, which is the trachea. It's very important to check that the trachea is midline, okay, and we can assess that just by holding our fingers on either side of the trachea and just assessing that the trachea is actually sitting in between those areas. Try not to push too deep there, because if you push too deep it gives you a bit of a harsh voice afterwards, and it can be actually quite uncomfortable. Okay, you can just relax your head now. Okay. It's good that Christian actually is holding his neck like that, because you can see many of the other muscles that actually can be involved in controlling the respiratory rate. Alrighty. Okay, some of the other landmarks that we do look for, if you run your finger down Christian's chest, you actually come to an area here. Now, what were we calling that before?
The sternal angle. The
sternal angle, excellent way. Okay, and the sternal angle is equal with what part of the chest?
Second rib.
The second rib, which is fantastic, so that we can actually see where the second rib is, and we can then feel for where the second intercostal space is. Okay, that's even with where we'd put the V1 and V2 leads for our ECGs, which tends to be where we associate that with. And then we can actually feel the third rib, the third intercostal space, fourth rib, fourth intercostal space, okay, and we actually come further out now, because the costal margin, which is this upside down V type shape, okay, actually starts going outwards. So we get down to the fourth rib, okay, fourth intercostal space, fifth rib, fifth intercostal space. Okay, now that's an important part, because when we also then measure the midclavicular line, what we actually then find is, okay, we need to find our midclavicular line. So here's your suprasternal notch. Okay, and what's the outward border?
The tip of the clavicle.
Clavicle, excellent, yep, okay. So halfway in between there and running a line down the middle, we've got our fifth intercostal space, midclavicular line, and that is where our apex beat is, okay?
Another important landmark is the mid-axillary line. Draw a line from the middle of the axilla down to the fifth rib. This reference point is where the lobes of the left lung intersect. To find T3, the upper margin of the lung, you need to locate C7.
So part of actually doing that is running our...
To do this, run your finger down the midline of the cervical spine until you feel a prominent bump.
C7. That sits directly on top of T1, which is your first thoracic vertebrae. Okay, so once we've actually identified that, we can actually just count down the vertebrae and processes and actually come to T3. Okay, so that is a reference point for actually telling, as we come around, for the upper lobe, okay, and also the lower lobe. Okay, so it creates that demarcation. Once we've found T3, we can actually move down to T4, T5, T6, 7, and 8. Now T7, T8 is about at the bottom edge of the bottom angle of the scapulae. Okay, and that's also a good reference point. And then T9, T10...
T10 is the lower margin of the lungs. As we inhale, this level goes as low as T12. Keep these landmarks in mind as you conduct the respiratory assessment.
Could you tell us why you've actually come into hospital?
The respiratory assessment, like all assessments, begins with taking a patient history.
Previous history of breathing problems or any injuries to your chest?
No.
Ask the patient if they have had chest pain, a cough or shortness of breath. Find out if they smoke or if they've been exposed to environmental hazards.
Not family problems, but I did once.
Take note of their general appearance and pay particular attention to their ease of breathing and skin colour. In this way, While taking the patient's history, you begin the assessment process. The process is designed around the symmetry of the chest.
In being symmetrical, we actually go from side to side and then from upper to lower and systematically down the chest. So we're actually comparing the different zones of the chest as well as the different lobes as we're going down. So there's a couple of things within colour that we look for, particularly looking for circumoral cyanosis, which is essentially blue tinging around the mouth particularly. So you just ask your patient, just open their mouth up slightly and just look for, it should normally be quite red, so if there's any blueness, blue tinge, cyanosis, that kind of thing. Might also look for pallor. Those two things might actually show other types of disease processes that might be going on, but essentially Christian's quite a healthy looking person, so we're not going to see that here, but they're good things to look out for.
Inspect the hands for colour and clamminess. Take the patient's pulse and check the fingernails for capillary return and signs of clubbing. When inspecting the chest, note its shape, symmetry and use of accessory muscles. Then note the rate and pattern of breathing. In this procedure, you will feel for the symmetry and the quality of vibrations at the chest wall. This is called tactile fremitus.
This is again to get him to cross his arms over at the front, okay, and essentially popping your hand and just using the ball of your fingers, okay, get him to say 99.
99.
Thank you. And again.
99.
And again.
99.
And again.
99.
And again.
99.
Okay, again, we're divided in half essentially, so we're again looking for the symmetry. Okay, now because the trachea breaks into the bronchi and the right bronchi tends to come back a little bit and down, okay, some people actually say it's stronger, or the fremitus is stronger on the right than actually on the left. Okay, and you do actually feel that in a lot of patients, and it's quite normal to actually feel a little bit stronger on the right than the left. Alrighty, and from there, what we might also do is again assess for that the degree of expansion of his chest. Okay, so we actually went down the spine and actually found T with the angle of the scapulae. What level of T?
T7 or 8.
T7 or 8. Okay, so then down to T10. If we actually get hands around and actually, it's like taking hold of the chest and just bringing pinching the skin together a little bit, okay? Then just asking Christian to take a nice deep breath. And exhale. Okay, so it expands in the same way and it actually then comes back in the same way. So he's actually got really good chest expansion, which is good to see. Percussion actually elicits any noises from, again, probably about 3 to 4 centimetres deep within the chest.
When you percuss, you are trying to elicit sound from the underlying structures. Percussing over air-filled organs will produce varying levels of resonance. Percussing over solid organs will produce a duller resonance.
Okay, but essentially what you're trying to do is create a surface area over which to elicit a drum noise through the skin and then get that resonance back. Okay, I actually find it easy just to use 2 fingers in between that, okay, and just doing, going down systematically through the chest. Moving around and just comparing the noises.
The final step is to listen. You listen from side to side as you move down the chest wall.
And open mouth, if you could just take some nice normal breaths, please.
After listening to the back of the chest, you repeat the assessment process on the front. Again, you will feel listening for
99.
symmetrical vibrations. Also take the opportunity to
Again.
note any scars,
99.
lesions and
And
moles.
again.
99.
Yep, that's good. That's good. See, it's a little bit duller there. It's quite. Okay, so that actually sounded quite drummy there, didn't it, compared to, it might just be the position I'm in, but it's quite flat there, whereas over here it was quite drummy, which is good, yay. Okay, and again, you're just doing it in a systematic manner, so if you want to have a go just working through
So
that.
similarly, the same sort of...
Same type of thing, comparing side to side and then upper to lower. Okay, and that all pretty much fits in with what you would expect with the underlying organs, that kind of thing. So that actually worked out really well for you.
Okay.
I think you did your percussion a bit better than what I did. I wasn't listening to the same type of noise. Okay, so from there, again, with your stethoscope.
As you auscultate the chest, you will be listening for different types of sounds.
So we can again...
Around the neck, you will hear tracheal sounds.
Right, just breathe open through an open mouth. That's good. Okay.
At the apices of the lungs, you will hear vesicular sounds. Following are some sounds that indicate respiratory pathology.
one of the tricky things with this, because the heart's there, okay, you're going to hear some of those heart sounds, okay? So it's a tricky thing to try and block out those heart sounds so you can listen to the heart. But again, that comes with practice. So if you want to have a go at that.
Did you start?
Just softly, just between, in the suprasternal notch there.
If you could just take some breaths through your mouth. Thank you.
When you are listening to the anterior chest, focus your listening towards the breath sounds rather than the heart sounds.
I think that, yeah, the heartbeat gets in the way of it.
It does a little bit.
Becoming skillful in respiratory assessment takes practice. Following the systematic approach of inspection, palpation, percussion and auscultation is essential in developing your confidence in respiratory assessment.
Is there anything we can give you?
No,
for you?
I'm doing
No? Anything you want to ask of us?
No, not at all. As long as my lungs are sounding okay.
Alrighty. Okay.
No.
But you should always take every opportunity to explain to the patient that if they require any assistance with giving up smoking, this is your opportunity. Okay, that's cool. Thank you for that.
Thank you. Thank you.